I am Nicole Gackstetter. I'm a Quality Improvement Advisor with Superior Health Quality Alliance. Can everyone hear me? Okay. I want to welcome you all to session 2 of the Diabetes Affinity Group. Today, we're going to have Rachel Dibble with us, and she's going to be presenting on partnering to improve diabetes management. And with that, I also have some colleagues of mine here from Superior Health Quality Alliance. And I'm sure you can see them all on screen. We will also be presenting some future topics. On November 28th, we're going to be presenting on Diabetes 101, which will be continuing the conversation from today. On January 23rd, we're going to be talking about medication management. And on February 27th, we're going to be doing some talking about motivational interviewing. And so right now, I'd invite you all to enter your name and organization or facility and role into the chat so we can see who's all here with us today. And next, I want to just share some group guidelines with you all. When sharing case studies, stories, or scenarios, just want to remind everyone to refrain from sharing personally identifiable information, or PII, and protected health information, PHI, so names, birth dates, medical numbers, social security information, etc. We want to request and encourage everyone's participation, so contribute ideas, perspectives, questions, and concerns. You can just unmute yourself, or you can go ahead and put that in chat. Also want to remind everyone to respect each other's ideas and be open-minded. Seek first to understand and then to be understood. Be courteous and ask questions. Test your own assumptions. And do all things with respect. And with that, I'm going to turn it over to Rachel Dibble to go ahead and get us started with the session. Rachel?
Thank you so much, Nicole, and welcome everyone. I'm excited for this talk about management of diabetes. As we know, it is an escalating strain on patient care and also fiscally, particularly with Medicare. So there are a lot of new information rather, coming out that I hope to share with you today. So for this talk, the objectives. So at the conclusion of the session, attendees will be able to understand the pathophysiology of diabetes, evaluate who is at risk for diabetes, and identify signs and symptoms, diagnose and treatment of diabetes. Next slide, please. Next slide, thank you. So to get a baseline of some of our understanding, I do have a polling question just at the beginning to see what some baseline knowledge is. So if you don't mind, please answer the question. And the question is, for a person with diabetes who has good glycemic control, what effect does exercise have on blood glucose? Look at that. 100%. That's incredible, awesome, wonderful, correct answer. Thank you. Next slide, please. So what is diabetes? We all have, I'm sure, encountered diabetes with patients and otherwise, or coordinating care. So the down and dirty of diabetes basically is that the pancreas secretes the hormone insulin. And so insulin carries the glucose from the blood into the cell, which we know. And then once glucose is in the cell, the glucose is then converted into glucagon, or energy. And then glucose remains in the bloodstream. Glucose will build up when the pancreas does not secrete enough insulin. So the last point is when it does not, which is really the crux of diabetes. So what happens just in a macro level, every organ, every tissue of your body is affected by diabetes. And I'd like to think of the visual of a garden hose And the garden hose is your vascular system. And then you have all these little dots, also known as cells, within your vascular system. And you have all the sugar hanging out inside the hose, but outside the cell. So what that sugar is doing is it is destroying your vascular system. So you can see the connection there, obviously, then why we get glaucoma, diabetic neuropathy, kidney damage, heart damage, all organs, because our vascular system is not at 100% because it's being damaged by those sugars that are hanging outside. So with exercise and glucose agents, it pushes those sugars into the cell, and that's where we want sugar to reside, in the cell. So if we're vastly uncontrolled, we have a lot of sugar outside the cells, tearing up our vascular system, aka our hose, basically our water hose. Next slide, please. So diabetes by the numbers. We read and hear about the big push in stage renal, in particular the last 10, 15 years as we've gone to managed care in particular. So these numbers and these statistics are really upfront for clinicians. So diabetes by the numbers. So total diabetes. So let's think about this. If we have, I believe we have 336 million people in the United States, I believe. So let's take that number and look at these numbers. So total pre-diabetes, 96 million. And then 26.4 million adults 65 or over also have pre-diabetes. So we're looking, 6, 7, 8, 100 million people. The cost of diabetes, so the total estimated cost of diagnosed, that's a big word because most often it's not diagnosed. So these are diagnosed diabetes in 2017 was $327 billion, including $237 billion in direct medical costs and $90 billion in lost productivity. So that $90 million in lost productivity, we need to then steer our head to thinking, what does that mean? Well, what that means is lost productivity can mean many things. That's loss in productivity with childcare, loss in productivity with work, loss in productivity with taking care of things at home potentially. And that gets into the fiscal element of then that patient may have big issues with affording medication and the cost of diabetes and chronic kidney disease. So we have to think of it in the psychosocial way as well. So excess medical costs associated with diabetes, think about this, were $9,601 per person in 2017. So if we do that math, that's how we get to the 327 billion. Next slide, please. So type 2 diabetes. So diabetes is the leading cause or a leading cause of kidney failure and new cases of blindness amongst the adults in the United States. So diabetes is associated with increased risks of cardiovascular disease, non-alcoholic fatty liver disease, and non-alcoholic steatohepatitis, and was estimated to be the 7th leading cause of death in the US in 2017. Now that data is 6 years old because I don't get CMS that sort of data. Usually it's every 2 or 3 years. So we know it's only escalating. So this was 6 years ago. So screening for these asymptomatic adults who may allow earlier detection, diagnosis, and treatment with the ultimate goal of improving health outcomes. And that's really the key. We got to screen. I also want to take a moment for the increased cardiovascular risk. It has just recently come out, and I'll spread the word, for cardiovascular metabolic syndrome. So they're starting to break down these issues with metabolic syndrome into systems. So it has now officially come out with the new term, and this is something really to look out for because metabolic syndrome, cardiovascular disease, and diabetes, they all go hand in hand. So keep your ear to the pavement and look for this. Next slide, please. So who's at risk for diabetes? The elderly, of course, over 65. Obesity and overweight. That is a a 2-second assessment of a patient. If they are overweight or are obese, they are at risk. They are at risk. And we know that our BMI chart is a really slim chart insofar as determining if someone is morbidly obese or not. It is a great guide. So if they're overweight, obese, or have a morbid obesity, you really need to start screening for diabetes. And they most probably 99% of the time also have hypertension, which then also affects the kidneys tremendously. And then you have the next problem, the diabetes on top of that. So you can see how chronic diseases can stack onto each other, with diabetes maybe being the first one. Women with polycystic ovarian syndrome, gestational diabetes, 45 years of age or older, a first-degree relative with type 2 diabetes, physically active less than 3 times a week. The recommendation is 150 minutes per week, however you can fit that in. History of gestational diabetes again, non-fatty liver, non-alcoholic fatty liver, and then of course our ethnic groups of African Americans, Hispanic, Latino, American Indian, Alaskan, Native, and American people are at higher risk for diabetes. Next slide, please. So how do we screen? Well, the good news is that screening is really easy, and it's really effective, and it's cheap. And so we really have the tools and usually the resources to be able to screen for type 2. So your first screening, of course, is your A1C, and that is your 30-day mean. Sometimes this will go to your practice policy guidelines. Typically, the diagnosis for diabetes is a fasting glucose level. But of course, through your A1Cs, your 90-day trends, you can see where people are varying and see a historical trend that way. And then random glucose, blood glucose levels as well could be a good indicator, particularly if people are running hyperglycemic and they don't know it. And you say, hey, just poke your finger and let's poke your finger and see what your sugar is. And it may be at 500. Well, unless they just ate a candy bar, we're probably onto something insofar as diagnosing. Next slide, please. Signs and symptoms of type 2 diabetes. We know these ad nauseum as well. We've been educated, we see it, we hear it, but sometimes they are missed. And so really think through, because if we can catch diabetes, be proactive, the amount of chronic diseases, as I said before, we affect every system in the body. So the yield or the opportunity cost of diagnosing and treating proactively could save this patient for 6 or 7 chronic diseases. So this is a really important to be pay attention to these things. Urinate frequently, and I mean urinate like constantly urinate, and that would be a major indicator. Thirst, and then someone's drinking a gallon of water. Now we're going to have electrolyte problems. So someone who is constantly drinking, and I'm talking a gallon or 2 of water, I mean, much more than the recommended 8 glasses, 32 ounces. Losing weight without trying, huge indicator. Hunger, blurry vision, numbness and or tingling of hands and or feet. There you go with your system getting damaged, your hose with all of the glucose on the outside of the cells. Lethargy, very dry skin. As a clinician, I have diagnosed, or let me rephrase that. It guided me to test because of the urticaria, which is just, and it's literally this, someone itching like this. The itchy skin typically can mean some kidney damage, which could mean diabetes. Slow healing, huge indicator. Infections, and then fruity breath. It literally, breath smells like juicy fruit gum. Fruity breath, great indicator of signs and symptoms. Next slide, please. So type 2 diabetes, here is the actual guide. So diabetes A1C 6.5 or above, and the cutoff is 126. 126 or above, you are diabetic. Then you have your GTT or your glucose tolerance test, and then your random blood test, 200 and above, that's like, we may be looking at this unless you just ate a candy bar. Pre-diabetes, 5.7 to 6.4, 100 to 125. So if you're 126, you are diabetic. GTT test while pregnant, of course, 140 to 199, and then random's not applicable. Then you have your normals in your 5.7 range. That's 99 or below, at 140 for your GTT, and then not applicable for your random. This is the guideline for people that are 65 and below. The guideline for people that are 65 and over, they vary a bit. They give them a lot more wiggle room for the sole purpose of hypoglycemia. As we know, our geriatric patient, as they age, they lose their fat. They become thinner. They're not eating regularly. Their cognition, maybe they don't remember when they ate last. All of these things, and what the data revealed was that we were doing more harm than good by keeping them on strict glucose. And so we give them a little more leeway because the risk is hypoglycemia. And again, they took their medication, they forgot to eat. And that's a hip fracture. That's a surgery. So keep in mind those guidelines are much looser on the 65 and over population. Next slide, please. Next slide, please. So treatment options for type 2 diabetes. Obviously, you have your insulins, you have your long-acting, your short-acting, you have your 70/30s, your MPHs, etc. But insofar as keep in mind that your insulin for your type 1, those are the people that don't have beta cells. They're not producing insulin at all. So, your type 2s, obviously, need insulin sometimes if they are insulin resistant, meaning their insulin is not enough or not potent enough. So sometimes we do insulin. Then we've got our metformins, and that's really trying to get that patient to do some lifestyle changes. That we're pre-diabetic usually is a good choice for metformin that's below 126. Then you have your sulfonylureas. You can say, I won't list all of them for you, but you have your SGLT2s, your bile acids, your GLP-1 receptors, and then of course diet and exercise. And that is the key. Obviously, it is the key. Lifestyle change, getting people ready to change and making those changes. Obviously, we know are very difficult. Then you look at the economics of someone maybe who's on a fixed income. Again, difficult. Fresh, good food is expensive. So it is hard for people in the community to have access one, and then funds to be able to afford these sorts of nutrients. Next slide, please. So hypoglycemia assessment. So I talk about this again, it is one of the major risk factors for our diabetic population, particularly our elderly, for their hypoglycemia risk. So the factors that increase the risk, the use of insulin or insulin secreting drugs. And again, we want to ensure, we rather our geriatrics run a little high than run too low. Frailty and older age. Adipose tissue is decreasing. We don't have as much fat. Cognition. Oh, and often I do remember with my stepfather, he would take his diabetic medication probably 2 or 3 times a day when it was prescribed once a day because he forgot. So we can see how this can build on each other, why diabetes is such a big topic. Impaired counter-regulatory responses to hypoglycemia. Our brains are atrophying as we age. So things aren't regulating the way they used to. Oh, I'm hot. Oh, I'm cold. Oh, I'm dizzy. It may not happen the way it did when someone is 65, 70, 80, when they were 50. Behavior responses to hypoglycemia. Unawareness of physical or intellectual disability that may impair. I tell a story often. I used to work in the ER, and Often, sometimes people were accused of being drunk or on drugs when they were just really hypoglycemic. That's what it ended up being. So making sure we're not using stigma or judging, and really ensure that our patients are taken care of. Alcohol use, big cause of hypoglycemia. Polypharmacy, in particular, is ACE, or angiotensin reception blockers, and our non-selective beta blockers. So when I say ACE, I know some of your ears might perk up and say, well, wait a minute, we're supposed to put them on 5 milligrams of lisinopril, ACE inhibitor, if they're diagnosed with diabetes, to protect their kidneys. So that is a low dose. So it's once we get into higher doses that we have to really start looking at the hypoglycemia potential event. And then history of severe hypoglycemia. That tells us a lot. Impaired kidney or hepatic function, that is 9 times out of 10 the problem. We are not metabolizing medications the way we used to, particularly in older age. And then the longer the duration of diabetes, obviously, you have effects. Hypoglycemia could also occur because of that. Next slide, please. Immunizations for type 1 and type 2 diabetes. We all know this, CDC puts them out every year, but I'll just go through them again, because our diabetic population, they're immunocompromised, period, the end. And typically they have 4 or 5 other chronic diseases going on. So let's ensure we have our diabetic patients immunized. So COVID-19, obviously your influenza, pneumococcal pneumonia, your Tdap, zoster, Hep B, and HPV. I think the cutoff for HPV is 26, and then you talk to your provider specifically if you do find that you would like that. Next slide, please. So with everything being said and done, the one thing that I would love the takeaway to be is the focus on patient-centered care. Diabetes management, diagnosis, and treatment does not work unless it's patient-centered. These are not one-and-done conversations. This is about someone potentially changing their entire lifestyle to regulate or prevent diabetes. And that can be every single thing they ever put in their mouth, they no longer can now or want to change. And that is a baby step approach. Very rare that someone says, I'm going to quit everything at once, and they stick to it. And that's where the mentoring, the guidance, the clinical education. Do you know what a bowl of pasta has in it? It's carbs. Often, as we know, some people think it's just the sugars that are in candy bars. It's not, it's those carbs. So a lot of that comes into, and then I always bring up too, particularly now because of inflation, groceries are so expensive, beyond expensive, making some good choices. So I urge you, patient-centered care is so important. So assess key person characteristics. That's occupation. You know, is it 30 minutes to a grocery store? What is a day in the life of, Mr. A look like? What does your day look like? How do you get to know your patient? Ask these questions. Consider specific factors that impact choice of treatment. That could be, you know what? I work until 8. There's no grocery store. There's no restaurant. There's nothing around me. My weekends are full, and I get home and there's nothing to eat but a bag of chips. So look maybe at a time management. What can we do? What's easy? What works for you in your world where this change is possible? Because they can do it, and it's our responsibilities to give them hope that they can do this. So utilize shared decision-making to create a management plan. Often patients will yes you to death. Yes, I can do that. Yes, I'll do that. Really dig, be empathetic. People living with diabetes, chronic kidney disease, and stage renal disease, quality of life is not awesome for them. Implement a management plan and agree on a management plan. How are you going to do this? Educate on the why. And once this puzzle is put together, the momentum of a patient wanting to participate in this chronic disease is much higher. Provide ongoing support and monitoring choices. My brother, for example, says, I eat great. I'm eating, 5 pounds of berries a day. And I'm like, okay, let's look at what kind of berry and how many carbs are in that. He had no idea. So a lot of this is just knowing where to access information and helping your patients stay on track with questions. It's that relationship and that collaboration. And then finally, review together and agree and how and be specific. On the front end, it takes time, but you'll say that on the back end, and your patient care will be better on the back end. Okay. Next slide. So takeaways: diabetes, patient education, compliance, and patient-centered care are really the big takeaways here. The management of glucose, of course, and proactive care. And your first indicator, someone walks in or you see someone who maybe isn't on any kind of diabetic medication, and you can see that they are obese, that is their first indicator. And see, it doesn't mean that they are, it means that it's when you start your critical thinking. Okay. So patient education, and these links are sent as well. These 2 standards of care, this is the whole version, by the way, if you want to know diabetes A to Z, and education and support living with diabetes as well for the CDC. But the PDF is a robust handbook, but it does have some great information and more changes than I have gone over in this presentation. So we will briefly, about 12 minutes or so, to go over a case study. And please shoot your thoughts, and I will throw out questions in there as well. But I really want you to look at particularly this case from the angle of within the presentation to the clinician and the clinician to the patient, back and forth. What are some of the key words that make your antennas go up? Are key things that were missed? Or key things that maybe weren't communicated properly? So keep those things in mind as I read this case study. Okay. So patient AB is a retired 69-year-old man with a 5-year history of type 2 diabetes. Although he was diagnosed in 1997, he had symptoms indicating hyperglycemia for 2 years before diagnosis. He had fasting glucose records indicating values of 118 to 127, 118 to 127, which were described to him as indicative of borderline diabetes. He also remembered past episodes of nocturia associated with large pasta meals and Italian pastries. At the time of initial diagnosis, he was advised to lose weight, at least 10 pounds, but no further action was taken. He was referred by his family physician to a diabetes specialty clinic. AB presents with recent weight gain, suboptimal diabetic control, and foot pain. He's been trying to lose weight and increases his exercise and has increased his exercise for the last 6 months without success. He had been started on glyperide 2.5 every morning, but he had stopped taking it because it made him dizzy, often accompanied by sweating and feeling a mild agitation in the late afternoon. He also takes Lipitor 10 milligrams, and he has hypercholesterolemia as well, and he's on medication for his triglycerides. And he's tolerated these medications well and adheres to the daily schedule of those medications. During the past 6 months, he is also decided to take a pancreas elixir in an attempt to improve his diabetic control. He stopped these supplements when he did not see any positive results. His lab results are his fasting glucose is 178, his creatinine is 1.0, sodium 141, lipids total is 162. Your healthy HDLs are 43. Bad ones were 84, your LDLs. Normal liver function, A1C is 8.1, and he is 69 years old. His albumin is 45. Normal is below 30. So on assessment, based on AB's medical history, records, physical exam, and lab results, he is assessed as follows. He has uncontrolled type 2 diabetes, greater than 7.0. He is obese, hyperlipidemia, peripheral neuropathy, hypertension, elevated urine protein, microalbumin, self-care management. He has limited exercise, high carb intake. He does not manage his, or he does not keep a journal for writing down his glucose. And he has a very poor understanding of diabetes. What should we do for this poor man? And his toe might be looking a little black, maybe.
So you can feel free to take yourself off mute and join the conversation. And you can definitely also put it in chat too, if you'd like.
And I was just going to share with the group too, if there was some of the information that you needed repeated, just let us know as far as, you know, what the fasting glucose was or things like that.
So let's think about this. So what would be the first, and so far as priority? So you kind of see kind of a potential train wreck happening. He's got unmanaged diabetes. We know he has some high cholesterol, some hypertension. His sodium's creeping up a little bit. So what would be some questions we would ask? Brand new patient, we just see his labs. Initial visit.
Rachel, I don't mean to jump in, but this case study is really challenging. Would you start out with identifying what the patient's goals are? I'm just thinking, you mentioned in your presentation, patient-centeredness. Would that be start?
And this is straight from the guideline. It is focused, Carrie, thank you, exactly on that. And what you do is you sit down with your patient, and you need to ask them, for example, with this patient, so when he presented with uncontrolled type 2 diabetes and a complex set of comorbidities, and he was looking at more comorbidities, right? Because he's been completely unmanaged, all of which needed to be treated. So this NP is looking, or doctor or PA is looking at this patient saying, oh my gosh, I've got 25 things to address here, because I also am seeing, I want to do some preventative care so our kidneys don't further decline, right? So the first task of the provider who provided his care was to select the most pressing healthcare issues and prioritize his medical care to address them with him. So he's peeing all night. He has nocturia. So he's going to the bathroom all night. That's because his diabetes is out of control, right? Because his A1C is above 8.1. So right there, our starting place would be, we got to get your sugar down right there. So how are we going to do that? Okay, AB, go run 5 miles a day and don't eat any carbs and eat, you know, fruits and vegetables and meat. Well, that's not going to happen. So then we start in with our open-ended questions, our counseling. What are your resources? Do you belong to a gym? Do you not? Where do you live? What do you eat? How do you know what your sugars are? Do you know what sugar does to your system? That's how we open up that education conversation. And then the second most important thing to do is control the hypertension. He was hypertensive. And just those two things, we have saved his kidneys in that case study. Anything, so what did you think about the patient's interpretation of what he thought he had? Remember, she's looking at his labs, and his lab says he is blood glucose of 127, diabetic. But what he heard was that he was pre-diabetic. So again, great teaching moment right there. Actually, you are diabetic. So right then and there, you know, I'd have to dig more into this case, but I would probably start on some metformin. Okay. Because metformin will work with or without the exercise, as we know, and even insofar as weight loss. GI issues with that, tell them about that. This is what that might look like. We can go up to 2,500 milligrams. I'm going to start you on 500 BID. Let's see how we go. Don't worry about exercise right now. Let's just get your sugars down. Why don't you come back in 30 days and let's talk about the next step. And that's how you start the momentum, and then you can build your plan. But the priorities with this patient is blood pressure and getting sugars down and making sure he understands his diagnosis, because he didn't know he was diabetic. All right. So the other obviously would be a referral for a nutritional registered dietitian. Dual eligible patients and Medicaid patients, it's Medicaid is state to state, so you have to look at it. They do provide resources. They do pay something. So that would be something else to refer. So I'll go on with this case a little bit. So the patient's wife, they did agree that a referral to a dietitian was their first priority, as well as getting glucose and starting medication. He acknowledged that he had little dietary information to help him achieve weight loss, and that his current weight was unhealthy and embarrassing. So then we're looking at a psychosocial. We've got confidence down in the toilet. He's been embarrassed. He's probably been shamed. Then we have medical. Then we have psych. Then we have to support him. Then we have to create a plan. And then he has to actually do it. So all of those steps happen in the first 10 minutes of your visit, really. Okay. He recognized that his glucose control was affected by large portions of bread and pasta, and agreed to start improving diet control by reducing his portion size. So that's a little goal on the first visit. Why don't you just do 2/3 of your portion? Let's see where we get there. It's all of these little supports. And at the end of the day, that patient, oftentimes they look over and they just want someone to care. And that's where we come in, right? So weight loss would be obviously very important as well with blood pressure. So that's how we synthesize all of these pieces and go, what's important? Blood pressure, glucose control, psychosocial, right? Resources. So the NP contacted the RD by phone and referred the patient for medical nutrition therapy. Medicare, Medicaid, and both will pay according to the guideline. By telephone, and referred the patient for a medical nutrition therapy assessment with a focus on weight loss and improved diabetes control. An AB's appointment was scheduled for the following week. The RD requested that during the intervening week, the patient keep a food journal recording his food intake at the meals and snacks. She asked that the patient also try to reduce portion size. So that was his only goal. So he had two things. So we didn't even talk really about diet exercise. We just said, let's do some portion control and let's write it down. So that's how you build your patient up to understanding what they are doing in their normal day-to-day active life. Obviously, we do unconscious things all day long. So after a week or so, writing all these things down, he realized that he really had no idea of what he was eating, what he wasn't eating. And he could understand now why his weight was not changing and why his weight was going up, in fact. So his wife suggested that the two of them could walk each morning after breakfast. They discussed that, and this is probably the third or fourth visit. They created a plan with the clinician, so everyone's accountable too. And that's how it has to be, really just accountability. I don't want to say life or death, but it is kind of life or death. It's not a quick death, but it is a gradual, and you will end up with end-stage kidney disease. diabetes if these things are not addressed. So they decided to walk every morning for 15 to 20 minutes. And I've seen patients start at 5 minutes. I've seen patients start at 2 minutes, literally, and I'll take it. That's great. Write it down, gold star. Really happy that you did that. So the first line of medication for this patient, obviously would be to look at some of the metformins, try to get the weight down, try to get the sugar down. And that's really a trial and error, going back, looking at the journal. When did you take it? How much did you take? What did you eat? How much did you exercise? All of that affects glucose, A1C management, and glucose management. So those journals are, as a clinician and as a patient, I think the most vital tool you can use as far as tools go, if I had to say. So then they agreed on the medication. They learned with the clinician the 2-step meter, how to take your glucose, when to take it, your fasting, after medication, before medication, whatever it is, if you're on short-acting, long-acting, pill form. So diabetes is kind of complicated. There's a lot of stuff if you have diabetes. You got to know, you got to order lancets, you got to order your controls, you have to keep your logs. I mean, there's all sorts of things. It's a full-time job. So they need our help and we need to support them. So we went ahead and we went ahead and started on metformin. We started exercising 20 minutes a day. And actually they were doing 6 days a week. So they weren't hitting the 150, but we'll take it. They cut portions in half rather, stopped the heavy carb diet. Then on the 7th visit, he comes back. He has no protein in his urine, and his blood glucose and A1C has been stable for 3 months, just with those interventions. I didn't change his diet. He didn't go run 5 miles a day. These were those tiny, tiny things. So you can do something as little as that for someone changing their entire life, and you can prevent diabetes, chronic kidney disease. And let me put something in there, except for obviously, the hereditary gene component. So that's the stepwise approach. You're an investigator with these patients. What do you have access to? What do you want? How do you want to live? Then you're going to have the patient that says, I just really don't care. I really don't care. And then you have the patient that's in your office because their blood glucose is, 130 and they're scared. So you're going to see it all over the place, but we need to support them, uplift them. And this is manageable disease. So next slide, please. And I would, we'll do the polling question again. And actually you guys got 100 on it, so we probably don't. So why don't I take this moment, and if you guys could please, just some anecdotes, anything that triggered something, a thought, an idea, a story, anything that you've seen in practice that you've heard about.
Yes, please, everyone. This is your opportunity to share. That's what this group is all about.
We learn so much from you this is why I love doing this, because we learn so much from your sharing.
Yeah, put it in chat. Take yourself off mute. What a great case study, Rachel.
Thank you.
I am not clinical by nature, so by background. So it's so interesting to hear.
I was going to say, I agree, Rachel. Great case study. I'd be interested, for participants still on this webinar, it was just kind of that overwhelming, all these things that it looked like, was going wrong with this, or I shouldn't say going wrong, but it had so many things going on is a better way to say it. And it gets really difficult then to, what do you tackle first? And kind of the way you broke it down, Rachel, was great. And I was just wondering, because I'm sure those on the webinar too have kind of been presented with these same cases and have not been overwhelmed by it, because I know you're all great practitioners, but just kind of wondering too, if you do have, examples or just even questions about, this, when you have so many things to look at, kind of picking out those things that are, most relevant. And sometimes, so here's a question for you, Rachel. Sometimes what we as clinicians feel is the most relevant and the first thing to be tackled is maybe not what the patient feels. So how do you handle that? Because it is patient-centered care too. So how do we go about doing that when doing what's right for the patient, but also hearing what the patient wants to focus on?
So, and that's often the case. You know, particularly clinicians sometimes get tunnel visioned and they're not maybe listening all the time to what the patient is saying. And so how I always navigate that conversation is to parallel what are the things we do have in common. Like, these are your goals, and then these would be my goals from a medical side. So, okay, we have 3 out of 5 that are the same. Terrific. Let's start with those 3. And then we have 2 that are way apart. And if the risk and benefit, or if the risk outweighs the benefit of really trying to navigate this patient towards this concept, it may be a hard push, or it may be something that we don't have to deal with right now, or something that is not, I would say, urgent, or something along the lines of we can compromise. I mean, insofar as diabetes, it's really probably I would say it's really the preventative care part, making sure your eyes are still working, making, neuropathy, all the things that can happen. Some people may say, I'm not going to the eye doctor, period, the end of story. Well, okay, this may be happening and we don't know it. And so often, just with education too, of my why, okay. Or sometimes they say, no, that's just not important. And then the job is to educate. This is what will happen. This is what we know. So I just want you to know this.
I was wondering, Nicole, could you pop to the next? I was going to say, I think we've got some questions there too.
Yeah. So we do have some questions here. We have just some things to get people thinking. So what are you doing in your care settings that is successful with managing diabetes? And it would be great if some of the folks in our group could share. Lindsay or Bria or Gayla, what are you guys doing?
This is Lindsay. This maybe goes a little bit better with kind of like the previous open-ended question. But I guess like where my mind goes is, especially when Rachel was talking about diabetes being complicated and multidimensional and multifaceted, and it's not simple. There's a lot of recommendations. There's a lot of monitoring, things of that nature. And we all know that compliance and adherence is a challenge. And so, when we talk about these different management and monitoring guidelines or recommendations, like blood sugar testing and getting your hemoglobin A1C and annual foot checks and eye exams and things of that nature, when we educate and talk to patients or individuals with diabetes about all these recommendations, I imagine it can be very overwhelming when you're talking about, like, you need to do this, 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 and this. So I guess my mind always goes to, what is it? I know there's not one best approach, but what are some strategies that really can help support that individual in their journey and their their lifestyle changes and things of that nature, really to help simplify it. And maybe, is there an approach to taking one recommendation at a time and like conquering it that way? Is that less overwhelming? Is that useful? Just kind of thinking about those ways and how to better address, and support compliance and adherence to those kind of recommendations.
Yeah. And I think, success breeds success. So it doesn't, to your point, it's really one tiny change at a time, right? Because at the end of the day, if they feel successful, like, okay, just eat 2/3 of what you used to eat. So they're doing that. It breeds more. Okay, what can I do now? I did that. Let me do more. I mean, but they're very small non-intimidating small things for the most part. Someone might look at that as it being intimidating that you can't, the recommendation is to not eat all of that. But I feel like when you get enough little wins at the beginning, that starts the trust. It starts the conversation. It starts the ball rolling. And once you start feeling better, because they will start feeling better, they're going to want to continue.
Sure.
So these are kind of all the little, I would say, implied things that happen for that motivation to continue. And that's why I never just lay out all the 5,000 things you need to do in the first couple of visits with diabetes. It's too much. It's like,
Sure.
Forget it. Yeah,
Thank you.
absolutely. Absolutely. That's the method I have found. The less is more, and just more frequent visits, maybe.
Sure. That makes sense.
Thanks, Lindsay, for speaking up. Thanks, Rachel.
Can I ask a quick question here too, Rachel, and for those on the call? I'm wondering, is it okay, because I've heard this before too, where you do like kind of the 80-20 rule? Because sometimes I think it'd be overwhelming for patients that, okay, you have to do this for every meal has to be appropriate or something. And I think sometimes that's hard for patients. Whereas you can explain to them, as long as you're doing this, 6 out of 7 days a week, or
Absolutely.
exercise, because I think sometimes people get caught in that. I have to do this every day for the rest of my life.
Yes.
And that's hard.
Yeah. And if you look at it that way, I haven't seen yet a change theory that says if you just go make drastic changes that they stick. They don't. It's creating that habit and giving up something little, and then having, that wasn't so bad, so let me give up something a little bit bigger now. It's baby steps. It's truly what it is. Of guiding that patient.
We have
Yes,
something in the chat.
that's good.
Kayla put something in the chat. She said, we teach our staff to meet patients where they are and then build a plan with the patient to go to the next step.
That's it. Right on the money. That's it.
Thanks, Kayla.
Thank you. Yeah.
Can I ask a question of our group again too? So for a lot of you, and Rachel, you talked about this, well, maybe it's more frequent visits. Are some of you using maybe like telehealth for those, what I would call in between visits, so the patient doesn't have to come in every time to maybe go through what they're doing? So kind of a combination of that. Just wondering if that's what you're doing and how that's working. Or maybe a virtual visit is a better term.
That's a good question, Barry. We're not using telehealth as much. Okay, well, Jerry, I don't think, maybe we're not using telehealth as much, so sure if we're gonna hear an answer to that one.
That's okay. That's fine. I know we're kind of getting short on time here too, so.
We are getting a little short on time here, so I'm gonna go to the next slide here. Rachel, thank you so much for your awesome presentation. And thank you to all the attendees that have attended and contributed. I do want to ask everyone to please fill out the evaluation link. We so appreciate your feedback. It's really important to us as we go forward. I do want to plug quickly that we are going to continue this conversation on November 28th. We're going to be doing a Diabetes 101. On January 23rd, as you heard at the beginning here, we're going to do a medication management. And on February 27th, we're going to talk through motivational interviewing. And then we also wanted to let you know, if you're not doing this already, to please sign up for the Superior Health Connect. This link that's on here goes directly to the Diabetes Affinity group, which is this group. And I think Jerry's going to put that also in the chat, so you can go ahead and click on that. Again, it goes right to the Diabetes Affinity group. This is a place where we share the Diabetes Affinity. We can share information there. It's a safe place for people to connect with one another and to talk about issues and things that they're working on, or share best practices, share resources. The regular Connect page is also a place where you can share diabetes in general information. Carrie, would you have anything to add to that about Connect?
No, just on that page, we'll be posting also like the links that we have here in chat, and we'll post the recording to this presentation as well. So that's where you can find it.
Thanks, Carrie. And then next steps are for future registration sessions. I know that all of you are registered, but please invite your colleagues. If there's anybody that you know of that you think would be interested in this group, they can register here. They can also sign up for the Superior Health Connect, and you can reach out to Carrie or I with any questions that you may have. And we will look forward to seeing you next month to continue this conversation. Thanks, everyone.